A very good evening to one and all. The title of my presentation is Role of Amniotic Membrane Transplantation in Treating Acute Ocular Manifestations in Stevens-Johnson Syndrome and its Long-Term Impact. There is a prevalent thought among clinicians that if a patient develops Stevens-Johnson Syndrome, his or her fate is largely dismal. And this is very natural to have this thought because in day-to-day practice, we come across patients with chronic sequelae of Stevens-Johnson Syndrome who end up having corneal vascularization, lid viper keratopathy, and severe dry eye. So can we actually change the disease course? Let's know about this in the further presentation. I will take you through a case of an 18-year-old female who presented with sudden onset rashes all over the body, photophobia, redness, pain, and diminution of vision for the last 10 days. She was a known case of seizure disorder and was on various anti-epileptic medications, and recent addition to her treatment regimen was lamotrigine, which was 6 weeks ago. And suddenly she developed sudden onset rashes all over the body. There was painful swallowing, and there were blisters all over the body. So on examination, systemically, she was conscious, coherent to time, place, and person. There was rashes all over the body. There were multiple flaccid bullae and purpuric macules with sheet-like epidermal detachment with multiple mucosal site involvement. So we made a diagnosis of Stevens-Johnson syndrome. The patient was admitted and was started on systemic steroids, that's pulse steroids. And this was the clinical examination. These are the ocular findings. Her visual acuity in the right eye was 3/60, and in the left eye it was hand motions with accurate projection of rays. The extraocular motility were full and free. There were scabs all over the face. On examination of lids and adnexa, there were scabs over the lids. The lid margins were deepithelialized. There was crusting at the lid margin with matting of eyelashes, and there was mechanical eversion of the lower lid margin and temporal ankyloblepharon. On examination of the conjunctiva, there was diffuse bulbar conjunctival congestion. There was blanching of the palpebral conjunctiva, and there were true membranes over the surface. There were desquamated sheets of conjunctival epithelium, which was attached to the posterior lid margin, and that was also overhanging the cornea, and there were nasal and temporal symblepharon. As far as examination of cornea is concerned, the right eye showed diffuse punctate erosions, whereas in the left eye there was total epithelial defect with stromal edema, precluding anterior segment examination. This is the clinical picture of the right eye, wherein we can see that the red line shows the gray line, the green line shows the posterior lid margin, and the structure behind the posterior lid margin, this one is nothing but the deepithelialized conjunctival and corneal epithelium that is attached to the posterior lid margin, and the symblephra has been shown in yellow. So we made a final diagnosis of Stevens-Johnson syndrome with both eye grade 3 ocular involvement and planned for both eye membrane peeling with amniotic membrane grafting under general anesthesia or sedation. So here is a video of how we went ahead and did amniotic membrane grafting for the patient. First, we irrigated the ocular surface. Then the necrosed conjunctival membranes were peeled off the ocular surface, the palpebral conjunctiva. The symblephra was released, and the fornices were also swept to break any adhesions. Now, after placing the speculum in place, the amniotic membrane was placed over the surface, and once the amniotic membrane was spread all over the ocular surface, it was fixed with the help of a ring that was made out of an infant feeding tube. This facilitated stretching of the amniotic membrane not only to the ocular surface but also reaching the superiotemporal fornix, not just superiotemporal fornix but all the fornices, but the fornice that is more important to us is the superiotemporal fornix, because that is the place where the lacrimal gland ductules open up. So once the amniotic membrane is in place, stretching over the fornices, and now the redundant amniotic membrane, which is here, was reflected onto the lid margins to cover the deepithelialized lid margin. Post-operatively, the patient was started on following medications, and this is the clinical picture at day 7, wherein we can see that now the patient is opening her eyes comfortably. And this is at 2 weeks. Now coming to the questions that we had raised in the beginning, can we prevent the corneal vascularization? Can we change the disease course? We know that considering the fact that this is there is exuberant inflammation in cases of Stevens-Johnson syndrome, it has a potential to damage the limbal stem cells that lie deep down into the limbus. So definitely doing amniotic membrane transplantation at the early stage can prevent damage or mitigate damage to the limbal stem cells, and thus we can prevent corneal vascularization. And this is the clinical picture that is at 1 year follow-up. The cornea is absolutely clear. Now coming to the second question, can we prevent lid viper keratopathy? Again, the inflammation component can lead to exuberant deposition of keratin at the lid margin, and there is posterior migration of the mucokeratinase junction. Here in our patient, we can see that there is conjunctival scarring, there is meibomian gland atrophy, however, there is no lid margin keratinization and no lid viper keratopathy even at the end of 1 year. Now coming to this third question, that can we prevent severe dry eye? As I said while I was showing the video, that the superior temporal fornix is the site which we are more interested in, because that is the site where the lacrimal gland opens up, and if there is scarring at that site, it can result into the obliteration of these the lumen of these lacrimal ductules, and the patient can land up into severe dry eye. But these are the serial photographs showing active tear secretion in the right eye as well as in the left eye. So the take-home message here is that one should have a lower threshold for doing amniotic membrane grafting in patients with Stevens-Johnson syndrome, and acute inflammation, if it is controlled well in time and well in advance, can actually change the disease course. Thank you.
Yeah, nice talk. Which do you apply it in the ICU setting, or do you take the patient to the OT usually?
So we had planned to take her to to do it at bedside, but considering the fact the patient was having recurrent episodes of seizures, so we had to take her to OT.
Okay. And do you apply sutures, or you just?
No, we didn't apply sutures. Just the ring was there, and we just reflected it onto the surface. Once the amniotic membrane dried up, it stayed over the lid margin as well.
Onto the skin also?
Yeah.
Okay, and do you use cryopreserved, or you use?
Yeah, that was cryopreserved amniotic membrane. Actually, we had to procure it from one of the places that we.
You don't prefer fresh?
Yeah, fresh one. No, that was the cryopreserved one, the one which we used.
Okay.
Yeah. Thank you.
So how many times do you have to apply it, or once?
Only once we had done, and it was on day 12 of her symptoms.
Okay, and later on you didn't have to repeat the process.
No, sir.
How do you decide the end point? Like, this is now, I don't need to.
So during follow-up, we used to see, is there any surface deepithelialized, whether the surface is deepithelialized, because we cannot take that patient again and again to the slit lamp, also to the OPD. So we used to go to the ward, we used to instill fluorescent dye, we used to use blue filter of the IO in direct ophthalmoscope, and we used to screen for any epithelial defect.
Okay.
Fortunately, we didn't saw any epithelial defect, and it healed with over time.
So the amniotic membrane, size of amniotic membrane, when you wrap over the eyelid margin, so it is over the eyelid or just till the eyelid?
No, over the eyelids.
Over the eyelid.
Yeah.
So it's a very good procedure, and in the acute cases, it really do wonders to go patient to shift into the chronic stage and doing lid margin keratinization and such a lid keratopathy and all the things it prevents very well. But the irony, only the problem is that very few patients come in this stage and reported to the ophthalmologist actually. Usually patient reported to ophthalmologist in the late stage only, because in the severe setting, ICU setting, nobody is taking care of eye, and only they are doing the life-saving procedure and all the things, and I get ignored.
Right.
So if it's reported early and it is done early, then the eye recovery is, I think it's a very wonderful procedure.
Yeah. Thank you.
You should read the paper of Dr. Daniel Gregory.
Yeah,
he was the one who started this from Philadelphia, USA.
Right.
Thank you.
So the classification system that I talked about, like grade 3, was from, thank you.